So the aims of objectives that we're going to do, so as we said, we'll discuss an acute scenario. We'll discuss how to perform a comprehensive cardiovascular exam, discuss the findings, interpret different types of heart sounds, as we said, and then we'll have a brief summary. If you do have any questions, by the way, feel free to just put them in the chat and we can answer them as we go. So the case. So in your OSCE, if we're doing an examination OSCE, you will get a brief sort of synopsis of a particular case, and it won't be too detailed. And this is an example of what we might have. So an elderly gentleman 4 days ago complaining of chest pain and noted on admission to have ST elevation in the following leads. So I'll just let you have a quick look and see it's lead 2, 3 in AVF. So have a think about the particular territory that will be on the ECG and which coronary vessel is potentially blocked. Now, you don't have to think long because angiography actually showed occlusion of the RCA, and after PCI, there was good reperfusion of the vessel. So effectively, this chap has had an inferior STEMI and he's had good reperfusion, and this was a few days ago. Now, 48 hours later, it was noted that this gentleman was snoring on his use. So this is what was going on. And the nurse pulls you aside and effectively says that because they were snoring, they've had a listen to his chest, and it doesn't sound quite right. Now, the nurse doesn't know what's going on, but they feel like it's appropriate for you to give your sort of clinical opinion. So you can see on the use score already that this gentleman's slightly hypotensive. His respirate's up a little bit, but he's not quite tachypneic. His heart rate's up a little bit as well, but he's not quite tachycardic. But he is a little bit hypoxic on oxygen. So what are we thinking already? I mean, if people want to shout out, feel free. I think that would be easier because I can't see the chat function, but if anybody wants to put anything in the chat. I know it's limited information, but if we do think this gentleman is post-MI, hypotensive and has low SATs with potentially abnormal heart sounds, well, we're thinking post-MI complications, okay? And a very easy way to remember actually the post-MI complications is through our favourite villain, Darth Vader. So if we have a look at the first letter here, it spells out Darth Vader. And this isn't an exhaustive list, but it's, I think for OSCEs particularly, and for junior doctors, it's very useful to have at hand to think about what could be going on. So again, we won't go through the answer at the minute, but just think that it's post-MI, so it's something going on here. Hypotensive with low SAT, so there's probably some respiratory involvement, and there's abnormal heart sounds. So these are new abnormal heart sounds. And when we think of abnormal heart sounds, we're thinking valvular disease as a hint. Okay. So we go to examine the patient. Now, in any clinical scenario, you would do an A to E, but for the purposes of this presentation, we're doing a cardiovascular examination, so a specific cardiovascular examination. And it's important actually in any examination to remember the core principles. So what I was taught was white, or what I like to remember is something a bit more, I'll just have something a bit more comprehensive, so it's whippy. And these are easy points that you can score in the OSCE station. So it's the simple things such as washing your hands before doing anything. Introduce yourself, so simple, hello, my name's Steve, I'm so-and-so. Make sure you've got the right patient, position them appropriately, explain what you want to do, and then expose them with their consent. And for a cardiovascular exam, you'd want them sat at 45 degrees with their chest exposed. And following that, any examination, you've got inspection, palpation, percussion, and auscultation. But the important thing about the cardiovascular exam is that there's very minimal percussion, but a strong focus on auscultation. So specifically with the cardiovascular exam, as we've discussed on the left, we don't have much of percussion. And on the right, we can see that the way I like to break it down is if we think about the exam in zones. So if we start peripherally at the hands and work our way up to the head and face, then down into the chest with the regions in between as well, you can't really miss anything and you can't go wrong. So this is an example of what it might look like for your wipe or your whippy, just to say, hello, my name is. This is what I'd like to do today. Do I have your consent, etc. We won't read through all of that, but if anybody wants the slides at the end, it'll be a nice example to read over. So, general inspection. From around the bed, first and foremost, what features do we want to be looking for with respect to the cardiovascular exam? Is anybody commenting, Graham? Or...
Nobody's mentioned anything in the chat yet. I'm looking at it if anyone does want to just pop anything in there.
Yeah, by all means, if people just bob things in, I'll keep talking. But the way I like to think of this, again, just being systematic in your own head, is if we think of an A to E approach, so A, B, C, D, E, and any features that relate to that around the bed, and then we'll look at the patient specifically as well. So around the bed, is the patient on any airway adjuncts? Do they have any ventilation, for example, ventilator? Are they on any oxygen or any inhalers that are surrounding the bed? So that sort of covers your A and B. And then we're thinking cardiovascular, so any fluids attached, any lines that the patient has, so central lines or arterial lines. Do they have, are they catheterized? Can we see what's in the bag? So is it red? Do they actually have output? And then cardiac monitoring as well, so that's important given the nature of this exam. And then the patient themselves, so again, thinking of an A, B, C, D, E approach. A, is the patient maintaining their own airway? Do they appear comfortable? Are they on oxygen? So it sort of ties over with the around the bed observations. Are they tachypneic? Is the work of breathing increased? What's the fluid status? So do they have IV access? Do they look overloaded or dry? And then do they appear feverish? Any evidence of scars? And finally as well, something that's can be commonly missed actually, are they wearing any bracelets or allergy bands? Because that can be an important feature to consider as well in acute cases.
Stephen,
yeah.
Say this is an acute scenario. How would you kind of just point out any obvious things at the start? I'd imagine it'd be quite time sensitive in examination.
Sure. So I think, yeah, of course, in an acute scenario, you do your A to E, and I feel just observation-wise, again, keeping this in your head, is there anything that jumps out of you? So, the positive findings, and it can be quite difficult to be systematic when you're pressured in terms of time, and also your thought process when it's stressful. But the patient observations are very helpful because the numbers can tell you a lot. So again, what's the blood pressure doing? So are they attached to, say, cycling blood pressure? What's the rest rate? And I would, again, just think about it in your head and go through it. So you might say that the patient's airway is being maintained. That's good. You talk about the GCS because that's related to airway management as well. And just things like that, really. Are they really sort of gasping for air? So is the work of breathing up? Does that make sense?
Yeah, that's great. Thank you.
Okay, cool. So the examination, if we get straight into it, looking at the hands and the wrist. So the nails and the fingertips, there's quite a lot going on actually in the cardiovascular exam and the peripheral stigmata. Now, if you start distally and work more proximally, things like splinter hemorrhages, you can see those in the nails. So they're small, they effectively look like splinters that can be features of infective endocarditis. Peripheral cyanosis, so we're concerned about this because this might be reflective of the patient's cardiac output. Do they have a reduced output? Are they hypotensive? Do they have any vasoconstriction, such as Raynaud's? Or do they have potentially a thrombus that's causing reduced perfusion? Shamrock's window, so reminding ourselves that's the distance between our nail beds when we put our fingers together. And if you lose that angle, that's suggestive of clubbing. And you particularly see that in cyanotic heart disease with right to left shunts. Tar staining, so does the patient smoke? Osler's nodes and Janeway lesions, just to mention those, so features of infective endocarditis. Osler's nodes tend to be more peripheral and they're painful, whereas Janeway lesions tend to be more on the palmar aspects of the hands and they tend to be painless. Quincke's sign, so that's an eponymous sign. So if you feel the capillary nail bed, so pinch in the end, you might be able to feel what's a pulsatile capillary bed. and this is suggestive of aortic regurg. You might do the cap refill time, and then other features as well, like xanthomata. So that's lipid deposits tend to be along the extensor tendons, which is suggestive of hyperlipidemia. And then having a look at that in the hand, so that shouldn't take you too long. If you do notice something, definitely say it. But if you don't notice anything, or that there's no point in reeling all of these off because it will take time. So just mention the pertinent positive findings really. And then in the wrist as well, you can feel, particularly in the peripheral pulse, you're feeling for the rate and the rhythm. So is it regular, irregular, and what's the rate? Do they feel tachycardic? So count for 15 seconds if you've got the time, multiply it by 4. Then if the examiner wants you to as well, do radial and radiofemoral delay, because any delay there might suggest some coarctation. And the reason for that is because with the coarctation, that's going to disrupt the flow of blood at the point of coarctation compared to before the point. So it means that you're going to get a disparity when the blood reaches that part of the vessel. And this is just to help visualize what we were talking about. So here we have splinter hemorrhages on the left. This is some xanthomata, so again along the extensor aspect of the hand. And then here is Osler's nodes, and I believe these actually still might be Osler's nodes, and Janeway lesions I think you might be able to see down here as well, but the resolution isn't fantastic. And again, just trying to appreciate, so we've got some clubbing here. You can see that there is lateral and AP or superior inferior widening of the ends of the fingertips, some tar staining and some peripheral cyanosis too. So if you do see this in the exam, or it's suggested in the exam, definitely say it. Then moving up to the arms. So brachial pulse, how do we find the brachial pulse? I used to find this a nightmare to try and find. But all you have to do, just get 4 fingers placed on the medial aspect of your ACF, and you should quite commonly be able to feel the brachial pulse in and around there. Blood pressure, so it's unlikely you're going to have to do this in the exam, but definitely mention it, and also have an appreciation that comparing both sides, if there's a disparity of blood pressure in the arms, then this would be suggestive of a dissection. So I'm sure Graham could tell us all about that. Acanthosis nigricans, so this is something that's a little bit more out there. And what this effectively is, so these are skin changes that you tend to see in the flexural folds of the body, and particularly the axilla. This is where you get hyperpigmented and hyperkeratotic skin. And it might be worth commenting on that because people that tend to get this tend to be obese, have Cushing's, hyperinsulinemic, and effectively all risk factors for cardiovascular disease. And then finally, we have the water hammer pulse. So again, one of those things that, at least for me, was taught in med school, but I don't feel like eliciting one was taught very effectively because I never knew how to do it. But in short, one, what is the water hammer pulse? So how do we do it first? So 2 ways you can do it, or you can combine them into one. So first of all, make sure the patient's not got any pain in the shoulder. If you feel for the radial pulse on their arm and then grasp the forearm with the other hand, quickly raise the arm vertically. And what you're feeling for is either a very pulsatile pulse in the radial artery that quickly falls away, or if you can feel the pulsatile forearm, then that would actually suggest aortic regurg, and that is a positive water hammer pulse. And what's happening there is because in the aorta, if you've got an insufficient valve, blood's just pouring back into the left ventricle, and that'll have an impact on the arterial system down the line, so you've got retrograde blood flow. Then from the arm, we move up to the head and face, so in that systematic manner. And again, I appreciate it is quite word heavy, so don't try and read all of this in one go. But if you do want to come back at it just to have a read, I'm more than happy to send the slides. But in terms of the head, so Demusset's sign. So these are all, again, it's an eponymous sign, and this is what is when you've got head bobbing. So if a patient is sat there and the head appears to be bobbing, this can be suggestive of aortic regurg. And something perhaps you've probably not heard of, but lighthouse sign. So I only heard of it the other day, but this is effectively where you get blanching and flushing of the forehead when, in respect, looks like a lighthouse turning on and off. which again is reflective of aortic regurg. Then from the forehead moving down to the eyes, there's multiple things that can be seen in the eyes, from conjunctival pallor, xanthelasma, corneal arcus, and I've got some pictures of that as well, so we can have a look at them more visually. Malar flush, so this is where we get similar to SLE actually, where you can get like a butterfly-esque rash over the cheeks. This is suggestive of mitral stenosis or potentially mitral stenosis. And looking at the mouth as well, so the angles of the mouth, if you've got any angular stomatitis, so redness and crustiness in and around there, it might suggest a mineral deficiency such as B12 or iron. Any central cyanosis, so looking at the lips or underneath the tongue, might be a right to left shunt. So this again is more likely to occur in congenital heart disease, but it from a cardiac perspective, but things like pneumonia or severe respiratory disease can cause central cyanosis too. High arch palate, so this is suggestive of Marfan's, and Marfan's is important to be aware of because there's increased risk of aortic regurg. And you've got petechial indentation, again related to endocarditis. And the Muller's sign, so another eponymous feature. Having a look in the mouth, if you can see a pulsatile uvula, this is also suggestive of aortic regurg. So you can see there's a lot of things, peripherally and more centrally, eponymous features and signs that are suggestive of particular diseases, particularly aortic regurg. And I would say that whilst it's worth knowing these, I wouldn't necessarily say that the patient doesn't have them if you don't notice them. And I'm led to believe that most of the urology patients will be healthy individuals, so it's unlikely that they're going to have these. So don't necessarily waste time saying them, but I think it's useful to know. So this is an example of what I was talking about. So if you just have a think what these might be, if we start from right to left, so we can see that what looks like lipid deposits in and around the eye. So this is an example of xanthelasma, so the peripheral equivalent of xanthomata. There's my mouse. So then we've got here as well, so we can see this copper-coloured ring around the iris. So when you get copper deposition in the anterior iris, this is what's called the Kaiser-Fleischer ring, and this is related to Wilson's disease. So Wilson's disease classically is so the liver and neurological involvement, but it can have cardiac involvement as well. And then here, similar distribution, but different colour, we can see a white rim. So this white rim is known as corneal arcus, or in elderly patients, it's can be referred to as arcus senilis as well. And this is actually an age-related condition in older people, such that it represents deposition of lipid in and around the iris. But these are all features to be aware of because they're cardiovascular risk factors. And again, this is the rash that I was alluding to, so you get this malar distribution, central cyanosis, and this isn't looking at the dentition, but rather at the angles of the mouth. So we can see here this red rawness that is, once you've seen it, you'll never forget, it represents angular stomatitis, or sometimes called angular cheilitis as well. Oh, okay, so I've just worked out how to access the chat. There we go. So then from the face, coming down to the neck, there are two things that we're primarily concerned about in the neck. First of all, we'll start with the carotid pulse. Now, the carotid pulse, it's very important to assess because it's our way of assessing the central perfusion, and it helps us determine what the character and the volume is like of our pulse. The peripheral pulse isn't as useful for that. Now, before actually palpating the carotid pulse, it's important we auscultate first. We want to auscultate for any bruits, and a bruit is representative of stenosis. And the reason we want to do that is because even though it's very unlikely, there's a theoretical risk that palpating the carotid could throw a clot, and we don't want to do that given the risk of stroke. So listen to the carotid. Where can we find it? So it's quite easy to find if you know your anatomy. So locate the larynx in your throat, locate the medial border of your sternocleidomastoid, and if you can't do that, you can turn your head in order to elicit the muscle. And just between those two structures and inferior to the angle of the jaw, you can find the carotid pulse. Place 2 fingers there and palpate. One thing to be very, very aware of is never palpate the carotid pulses bilaterally in any scenario. And the reason for that is because you run the risk of bilaterally stimulating the carotid sinus. This would cause massive parasympathetic discharge to the heart and potentially cause a vasovagal. And the last thing we want to do in an OSCE exam is cause the patient to collapse. Now, as we mentioned, we can assess the character and the volume of our pulse centrally. And there are 2 ones to, I think, mainly be aware of. One of them is a slow rising pulse. So this is where the amplitude of the force that's felt isn't felt very quickly, but rather it takes time, and then it falls off quite quickly. Whereas a bounding pulse or a collapsing pulse, so as we can elicit in the arm, is where we feel a very strong forceful pulsation against the hand, and then that pulsation very quickly falls away. So as an example, if this is a normal pulse that would feel, it's quite sharp upstroke and then it falls away. Whereas a bounding pulse would have a very, very high upstroke and then it suddenly falls away. So this is something like aortic regurg, and a slow rising pulse. This would be something like aortic stenosis, because if we think in aortic stenosis, we've got a reduced aperture through which blood can travel. So it means it'll take more time for the blood to get through to that vessel, hence the slow rise. And then the second thing we're trying to assess in the neck is the JVP. So the JVP, it could have a discussion on it by itself. You know, it's a very interesting topic, and there's lots of things that we can tell from the JVP. But from an OSCE standpoint, I think that a couple of things to be aware of. First of all, what are we actually assessing? So classically, the JVP is measured by using the internal jugular vein, but it can be quite difficult to assess the internal jugular vein. And this is because it sits deep to the sternocleidomastoid, and we can only really see the distal aspect of the IJV, where it sort of opens out between the sternal and clavicular heads of your SCM. So you can use the external jugular vein as well, that sits superficially. Where do they exist? So if you've got your patient at 45 degrees and ask them to turn the head to the left, then looking on the anterolateral aspect of the right side of the neck, that's where you'd expect to see the JVP or any waveforms from these. So what is normal? Well, again, we need to know our anatomy. So the JVP shouldn't be more than 4 centimeters above the vertical height of the sternal angle or the manubriosternal junction. And I've tried to elicit that here, that this is a second intercostal space and it's 4 centimeters vertically. Now, if the JVP isn't seen, that's good, because we shouldn't see it, at least during inspiration. And then when we're thinking of trying to elicit the JVP, we can do what's called hepatojugular reflux. So if you want to try and see it, you can press on the right upper quadrant of the patient's abdomen. And the reason we do this is because it helps push blood that's in the IVC up into the SVC and increase pressure in your jugular system. Now, if we do see a raised JVP, so it's visible above 4 centimeters above the sternal angle, which for reference is around the side of the base of the neck, then what could we do in this? So if we think physiologically, where does the jugular system drain into? It's into the SVC in the right heart. So if we have an obstruction along that route, or we've got an increased pressure in the right heart that's causing backflow of blood, so congestion, then this is going to cause a rise in the JVP. So anything such as SVC obstruction, if we've got right-sided heart failure, if we've got pulmonary hypertension, perhaps secondary to severe respiratory disease, these are all going to potentially increase the JVP. And then we get to the chest. So I think what we'll do actually, are we about 20 minutes in, Graham, or 25 minutes in?
Yeah.
Cool. So if you just have, I appreciate I've been speaking a lot. So if anybody does have any questions, feel free to throw them in the chat. If not, we'll just take 30 seconds just to sort of refresh, consider what we've been talking about, and then we'll have discussion about the chest. Or if anybody wants to shout out as well, by all means. No, fab. Okay, so when we're thinking about the chest, we've already had a general inspection from the end of the bed. Now we're having a more, oh, we have a question. That's not for me. Okay. Yeah, so when we're looking at the chest, a few things we can gauge straight away. Scars, okay? Does the patient have any scars? These could be surgical, these could be traumatic, but the main ones that we're likely going to be asked about are definitely surgical scars. So those to be aware of, things like midline sternotomy scars, as the patient had open heart surgery before. Lateral thoracotomy scars, if they had any surgery in the lungs before. Infraclavicular, so this can be left or right-sided, and this is because they may have had a pacemaker inserted, and you might be able to see that subcutaneously as well in and around the scar. Excuse me, mid-artillery scars, and something I've not included there, but things such as thyroidectomy scars as well, so at the base of the neck. And this is important because thyroid disease can have an impact on the heart as well. Any chest wall deformities? So barrel chest, pectus extravatum carinatum. So extravatum carinatum might be suggestive of, connective tissue disorders, and then any visible, as we said before, SVC or apex beat pulsations. There we go. So this is an example where you might see those scars. Now, just as a rule of thumb as well, is thyroidectomy scars in the neck can be very difficult to see because ENT surgeons tend to make the incision in the crease of the neck. So if you are suspicious of one, make sure to have a good look. Then palpation. So what are we feeling for when we're palpating the chest? The main thing we're feeling for is the apex beat. Where do we find it? So the midclavicular line in the 5th intercostal space on the left-hand side in normal anatomy. Now, it's okay to not be able to palpate the apex beat, and don't spend too much time trying to locate it, because again, it's fine to say you can't palpate it because there are multiple reasons why you might not be able to palpate it. Big one is obesity, so the patient's body habitus. If there's lots of subcutaneous fat tissue, it's unlikely you're going to palpate the beat. Obstructive lung disease, so barrel chest, or situs inversus or dextrocardia. And I've been caught out by this before. So, make sure you don't say that you can palpate it if you can't, because it's, the worst thing you can do really is lie in your uroscopy. It could be displaced. So if you are able to work out that it is displaced laterally, then fantastic. It tends to be because you've got a large heart, so things such as cardiomegaly, or in very, very interesting rare circumstances, you might get mediastinal shift. Now, in an acute scenario, you could think, okay, is this a tension pneumothorax? But it's unlikely you're going to be feeling for the apex beat. Rather, if they've got thoracotomy scars, say absent lunge sounds and a shifted apex beat, they may have had a pneumonectomy that's caused a mediastinal shift. So that's something to think about. And then assessing the character of the apex beat as well. So you should be able to likely feel pulsations on the fingertips when you're palpating the normal apex beat. But if it's heaving, so this is where the apex is very, very forceful, this is suggestive of LVH, because the majority of your apex beat, or the apex of the heart, is formed by the left ventricle. If it's thrusting, so this means you can feel the apex beat in a very large area, so not just in a very localized area. This suggests a volume overload, so left-sided heart failure. And then tapping is the classical way in which mitral stenosis is described. And accentuation maneuvers, so you might ask the patient to lie on their left-hand side from the left lateral decubitus position, feeling in the same region, and you might be able to feel it if you couldn't in the normal 45-degree angle. And then continued, so other things after the apex beat, we can feel for heaves. So this is where we place the ulnar aspect of our hand on the left and right sternal edge around the fourth intercostal space. And if we can feel our hands being pushed off the chest, this is suggestive of right ventricular hypertrophy. And thrills. So what are thrills? A thrill is a palpable murmur. And how do you palpate for this? So with the palm of the hand, just place it lightly on the chest in the 4 auscultation zones, which we'll look at in a minute. And if you can feel like a vibration, or if you can feel in effect it's as it sounds like a thrill in the hand, then this would be suggestive of a palpable murmur. And that's useful to know because it helps us then grade murmurs later down the line using what's called the Levine scale. And we'll have a look at that as well. Auscultation. So auscultation zones. So as we mentioned, there are 4 main auscultation zones to be aware of. We have the aortic, pulmonary, tricuspid, and mitral. So an easy way to remember this is all people take money, everybody's greedy. And those regions are, I won't say them out loud, but those regions are here. Now, an easy way to auscultate. So how do you auscultate slickly in the examination, and how do you do it correctly as well? So the important thing to remember is that you need to feel for the pulse, and you need to feel for a central pulse when you're auscultating. So you can feel for the carotid pulse using the left hand if you're right-handed. Make sure that you can feel that quite comfortably. And then with the right hand, you can start in any one of the zones and work through them systematically. The way I like to do it is start in the aortic zone, and then I actually like to listen for carotid radiation immediately, and then work through the pulmonary, tricuspid, and mitral, and then listen for any mitral regurg in the axilla. The reason I do this, and I hope you'll see a bit later on, is when you ask the patient to sit forward, this you do as part of an accentuation maneuver, and it means that as they sit forward, you can go straight to the base of the lungs, and it looks quite slick to the examiner. So when we're listening to each zone, make sure we listen with the diaphragm first, because this represents high frequency noise and murmurs, and then listen to the bell in each zone. So as we mentioned, there are some accentuation maneuvers. So when we've listened to the aortic zone, the carotids, the pulmonary, tricuspid, and mitral, what we can do is to accentuate any murmurs in the mitral zone, so in the 5th intercostal space midclavicular line. We can ask the patient to lie on their left side, so the left lateral decubitus position, and listen in the left axilla. Now, when we're doing this, make sure to ask the patient to take a deep breath in, breathe all the way out, and hold. And the reason for this is because any murmur that's on the left side of the heart, so aortic or mitral, is exacerbated at the end of expiration, okay? Whereas any right-sided murmur is exacerbated on inspiration, and that can be remembered by the mnemonic at the bottom, RILE. Once we've done that, we can ask the patient to sit forward, again deep breath in, all the way out, and listen over the aortic region and the tricuspid region actually, so the left sternal edge in the 4th intercostal space. And this is where we're listening for what's a diastolic murmur. It's very unlikely that you'd get this in your exam, and I wouldn't expect it to, but just to be aware that this is how you can accentuate that murmur. So any regurgitation from the aortic point of view, it's the diastolic murmurs. So there are 2 accentuation maneuvers there to be aware of. And this is what I was mentioning before. So now that we've already got the patient sat forward, we can listen, go straight to listening to the patient's back when we're assessing fluid status. Now, murmurs themselves. So I did mention we'll have a brief discussion about murmurs. First of all, I think it's important to recognize what a normal heart sounds are. So when we have the characteristic lub-dub, that's S1 and S2 respectively, and they represent closure of the valve, so not opening or blood flow through the valve, but the valve slamming shut. Now S1 represents the atrioventricular valves, your mitral and your tricuspid valves, and S2 represents your aortic and pulmonary valves. So the classic lub-dub, S1, S2. Now, sorry, I forgot to mention at the start, but if you've got headphones, please put them in. So I'm hoping this will work. I'm hoping this will play, and this will be just a representation of what normal heart sounds like. I'll just give anyone who's not got headphones a couple of seconds. And so just let me know if this does actually work. If it doesn't, then I can try and give an impression of what it sounds like.
I think you need to make sure you're sharing your sound as well as your screen. It should be
really?
Top of it.
Let's have a look.
Should be next to the green bar, the options.
New share or more? Oh, share computer sound, yeah. We'll try that again. Did you hear that?
Yeah, that was great.
Oh, brilliant. Okay, good. Just get rid of that. So yeah, so that's an example of what a normal heart sounds like. So there's a nice crisp first heart sound, so the lub, and there's a nice crisp second heart sound, so the dub as well. So it's lub dub, and there are no added heart sounds. So when we write 1 plus, so you might have seen in note 1 plus 2 plus 0, that means S1 is present, S2 is present, and plus 0 means no added heart sounds. Then, if we do hear any added heart sounds, if we've got a slick way of being able to describe them, it's not working. There we go. So if we've got a slick way of being able to describe added heart sounds or murmurs, then it'll look very, very good in the osteate, and it also helps us compartmentalize what we're thinking. Excuse me. Now, there are various ways in which we can describe a murmur, and that is based on what we can see here. So the quality, the shape, site, time and radiation, intensity and pitch. And I appreciate there's a lot going on there. And you know, if you don't have time or feel like that'll be too much to remember in an osteate scenario, that's fair enough. If you have your own way of describing murmurs, again, fair enough. But what I like to do is, again, in my own head, compartmentalize everything and just think of this mnemonic at the bottom, so QS strip. Or in most cases, it's just strip with 2 S's because quality tends to be quite specific to certain murmurs. So for example, a blow-in murmur tends to be aortic regurg, and you get rumbling murmurs as well. But if we just think of S strip, then we will see how we can use that a bit later on to describe a murmur that looks slick and is exhaustive as well. So the most common types of murmurs we're going to hear, there are 2 most common types. The first one is aortic stenosis, okay? So aortic stenosis is where we get a narrowing of the aperture exiting via the aortic valve, okay? And this most commonly occurs due to age-related calcification of the valve. So age tends to be a big cause of a lot of things. Now, when we're assessing for an aortic stenotic murmur, we're likely going to hear it loudest in the aortic region, okay? It occurs during systole because the stenotic valves don't open properly when we're trying to pump blood through them, and it's quite a harsh sounding murmur. So when we're trying to describe an aortic murmur, if we think about the strip, so S strip, we can think first of all about the shape of the murmur, at the site of the murmur, sorry. So where is it? It's in the aortic zone. When we're thinking about shape, so this is of the waveform, so is it monophasic, is it crescendo or decrescendo? And we know that aortic stenotic lesions, or I'll tell you now, aortic stenotic murmurs are crescendo, decrescendo. We think of the timing, so it's an ejection systolic murmur, and it tends to occur at the midpoint of systole. If we think of any radiation, aortic murmurs radiate to the neck. Intensity, so that will be dependent on what we hear. And as part of the intensity, when we mentioned before about feeling any thrills, this will help grade the murmur based on the Levine scale, which we'll come on to in a minute. And then the pitch. So this is where we're using either the bell, so for low pitch, or the diaphragm, and whichever one is heard best, we'll describe it in that way. So for example, if you were to hear an aortic stenosis murmur, you might explain it like this. So a mid-ejection systolic murmur, loudest over the aortic region, radiating to the carotids. It is loud with no palpable thrill and therefore grade 3 on the Levine scale. It is best heard with the diaphragm as a high-pitched murmur. Now, I think, that's quite exhaustive. That would pick up all the marks. But it's important to note that if you don't get all of those features, it's not a big issue. And particularly the Levine scale, I think it might actually be unlikely that they'd be marking on that. So that's perhaps more for interest than actual need to know basis. And this is what the waveform looks like. So when I'm talking about the crescendo, decrescendo, that means it goes up and comes down. Okay, so I imagine, my Italian or Latin isn't great, but crescendo, decrescendo, we have an S1 and we have an S2. The S1 can be difficult to hear, but you tend to hear the S2 quite nicely. And then this is an example again of the murmur type. So make sure you've got your headphones in, we'll just play that out. Okay, so that's an example of AS, and it's I think in essence it's just quite harsh sounding. So if you forget everything, it just sounds quite harsh. And then secondly, we have mitral regurg. Okay, so the most common cause of mitral regurg is again age-related, and we get prolapse due to what's called myxomatous degeneration, and that just occurs with age. This again is going to occur. Where is it going to occur? So it's the mitral region. Oh, good question. Yeah, no. So as James has pointed out in the comments there, aortic stenosis is it's very common in clinical practice, and you're most likely going to hear that, or at least be asked to describe it. And mitral regurg as well, because it's age-related. These are quite common murmurs. So thinking back to the way we're going to classify this murmur, what's happening? So during systole, we've got an insufficient mitral valve, and we'll get retrograde flow of blood through that valve into the atrium. So it's going to occur during systole. It occurs throughout systole because the valve is always insufficient. So it's pansystolic, and we hear it in the mitral region. With respect to radiation, we know it radiates to the left axilla, or I'll tell you now, it does radiate to the left axilla. And the intensity, again, that's respective of actually listening to the murmur at the time. So putting it all together, there we go. So you might describe this murmur as a pansystolic murmur, loudest over the mitral region, radiating to the left axilla. And then the intensity, so it might be soft, but in this case, let's assume it's loud with no palpable thrill, and therefore grade 3 on the Levine scale, best heard with the diaphragm, therefore high-pitched murmur. I hope that makes sense. And this is an example of what mitral regurg might sound like. So we can see here pansystolic, it's throughout systole, and it is a single tone, so the pitch doesn't change. Okay, so you might call it monotonic or monophonic rather. So I think this is perhaps more out of interest, and if you don't know what the grade is in the exam, don't try and grade it because you're only going to lose yourself marks. If you do feel confident though and you want to try and impress and potentially, if it is part of the mark scheme, get top marks, then having an appreciation of this grading system will be useful. But in effect, grade 3 is your cutoff, and what I mean by that is that there is no palpable thrill up to grade 3. Anything grade 3 and beyond, you have a palpable thrill. And then in each sort of section 1 to 3 and 4 to 6, it's based on the intensity and the loudness of the murmur. So 1 is barely audible, 2 is pretty audible, and 3 is loud. And once you get to 5 and 6, when you can get the stethoscope partly and completely off the chest, that's suggestive of quite an intense high-grade murmur. Now that's effectively covered the chest. And then we get to the fluid status. So remember, the patient still sat forward at this point. But this is all of that we've discussed is what we're thinking about when we're listening to the chest and we're listening for those murmurs. But when we're assessing the fluid status, there are 2 main things we can do. So auscultate the base of the lungs, and we're assessing for pulmonary edema. Now, pulmonary edema would be suggestive of left-sided overload. And the reason for this, if we remember our anatomy, the pulmonary vessels, so pulmonary veins drain into the left side of the heart. And if the left side of the heart is overloaded, so this is meant to represent the back. If that's overloaded, it's going to get congested into the lungs and it's going to fall to the base of the lungs of gravity, hence why we listen to the bases. Then when we're assessing fluid status more peripherally, we can feel the sacrum and we can feel for the legs as well. And what we're feeling for is pitting edema. And the reason we feel here is because the edema is gravity dependent. And if the patients lay down, the sacrum tends to be the lowest point. And particularly if they're sat down, the legs will be the lowest point. Now, patients can have edema, but there are differences between pitting and non-pitting edema. And if we remember it backwards, in as much as non-pitting edema tends to be caused by either thyroid issues, so hypothyroidism, like pretibial myxedema, or issues with the lymphatic drainage, okay? Any other form of pitting edema, especially bilateral pitting edema, tends to be either cardiac in nature, it could be renal in nature if we're thinking of nephrotic syndrome, or it could be nutritional in nature if you're thinking of hypoalbuminemia, which itself forms part of nephrotic syndrome. But in a sentence, what we're looking for is pitting edema. So I appreciate I've discussed a lot about the examination features there and not really related it to our case. So if we put 2 and 2 together now, there's only 5-10 more minutes to go, is that if we remind ourselves, we have a patient who is post-MI, they were hypotensive with low SATs and abnormal heart sounds, okay? So remembering our post-MI complications, there's probably some respiratory involvement as we've established with the low SATs, excuse me. And the abnormal heart sounds tend to be related if we think about valvular disease, okay? Not always, but in this setting and in most settings, that's what should be going through your mind. So post-MI complications, on examination, this is what we find. There are no peripheral stigmata of cardiac disease. So as James very correctly asked before, how would you describe this? So you might say on examination, this patient had no peripheral stigmata in the hands, in the arms or face, and the JVP was not raised. Okay, it takes 5 or 10 seconds, but it gets you through. And you might mention the blood pressure there as well. There is, however, on auscultation, a pansystolic murmur that's new, and there's coarse crackles at the base of the lungs. So, hypotensive patient with abnormal heart sounds, it's a pansystolic murmur, and there's crackles at the base of the lungs. Yeah, so does anybody have an impression? So if you do actually want to put any comments in the chat now, what are we thinking of?
I'll let you know what anyone says.
Yeah, sure. Or yourself, Graham, if you want to.
Yeah, I mean, I have to. So, I mean, it sounds like it could be a papillary muscle rupture causing a mitral regurg.
Yeah, that's
and if they've got struggle breathing, that could be a pulmonary edema, which secondary to that causing heart. The mitral regurg causing heart failure, which could cause the pulmonary edema.
Yeah, no, brilliant. That's spot on, mate. effectively, yeah, what I was trying to get at here as well is, I forgot to put it in, but just reminding where this patient had infarcted as well. So it was their RCA, so it was their inferior territory. And particularly, it's useful to know that in about 80 to 90% of patients, they're what's called the posterior descending artery that supplies the papillary muscles, or I think the majority of your papillary muscles on your left-hand side comes from the RCA. So that's when people are what are called right side dominant. And this guy's had an infarct, and he's got features of, as you very correctly pointed out, MR with pulmonary edema that's most likely secondary to that. So with that in mind, I think just relating it to the case, imagine you're in an OSCE station, you've picked up these findings, this is what you think's going on. Aside from resuscitation from an A to E point of view, if we're thinking specifically cardiac, what further investigations do you think you want to do to verify your suspicions? Again,
Anyone in the chat, give them a little chance to answer.
Yeah, sure. If people, I appreciate it's been very one-sided from my end, so people do want to start throwing things away.
Yes, so Cameron mentioned echo. Yeah,
I've got the chat up, I can see. Brilliant, yeah. So very right, he's only on a monitor at the minute, which is only one lead, so 12 lead ECG would be perfect. Echo, again, that's perfect. We're looking for evidence of any MR. What else do people want? If we're thinking in an OSCE, it's always good to give 3 further investigations at the end of an exam. If we think about the lungs, what did we hear?
I imagine you would like to do an ABG or a chest X-ray.
Yeah, no, absolutely. So, you know, an ABG could be pretty useful, but I think, yeah, a chest X-ray, because then we can see what's going on, and it's likely, you know, with sort of acute heart failure, you might see that pulmonary edema, and there are features as well, other features you might see. So you've got your ABCs of pulmonary edema, but we, you know, that's for another time really. But yeah, perfect. So echo, 12 lead ECG, chest X-ray. If you said all those 3 in an exam, ABG as well, you should get top marks really. So let's just okay, yeah, so perfect. And then cardiac ultrasound. So at the time, a bedside ultrasound is likely going to be TTE and not a TOE. So it's transthoracic and not transesophageal. So in summary, as Graham very correctly pointed out, there was a 68-year-old gent who was 48 hours post-MI and had acute onset of MR, and this was secondary to papillary muscle rupture, resulting in acute heart failure and pulmonary edema. Now, I appreciate this presentation. It was less to do with management and more just reminding ourselves of the examination features, but it's also important to think what investigations to want to do going forward. We've already discussed those, and the way in which you might summarize all of this is in that sentence there. So as we mentioned before about peripheral stigmata and the fluid status, because they have fluid in the lungs. Talk about what you've palpated and then the positive findings as well. So I feel this, you know, encompasses all the important information, but it's not going to be too time heavy. Now, I think this is the last slide. You'll be very happy to know. So other important things to consider as well during the presentation. Oh, comment. Oh, yeah, is, where are we? So metallic heart valves. So that's one thing that may be asked about. Giveaways for this, so if the patient has actual scars on the chest, and sometimes you can hear the click from the end of the bed. So when you are doing your general inspection, and if you think you can see a scar, just take 5 or 10 seconds to see if you can hear a metallic click. And I know that sounds simple, and you ask, well, what does that sound like? And it is in the name if you've never heard it before. It's just a clicking sound that sounds like it's coming from the patient. And then other features and investigations you might do to complete cardiovascular exam that's not necessarily specific to this case, but in general, if you're ever stuck, urine dip, you can never go wrong, hematuria and proteinuria, thinking hypertensive disease, because the kidneys go hand in hand with the heart and any heart disease. Peripheral vascular exam, fundoscopy if you're assessing for hypertensive retinopathy and Roth spots. So Roth spots are pertinent findings in infective endocarditis. Bedside capillary glucose if you're thinking diabetes, and any fluid, drug and diabetic charts. And I believe that's it. Yeah, so if anybody has any questions, feel free to just ask away. Otherwise, I hope that was useful in some way or another, even if it was just a recap. And for anyone sitting there, obviously soon, good luck.
I'll just stop the recording there.